Greetings and good morning, Dr. Wilson. My name is Muhammad Al. Today, our group will be discussing the issue of accessibility of healthcare services in Malaysia and Borneo, focusing on Sabah and Sarawak. So, firstly, access to quality healthcare is a fundamental pillar of an effective healthcare system. It ensures that individuals are able to receive medical care when needed, regardless of their location, income, or background. In Malaysia, equitable access to healthcare is recognized as a national responsibility and is reflected in national policies and development planning. However, Sabah and Sarawak present a unique context. These regions are characterized by vast geographical areas, low population density, and challenging terrain, including dense rainforests and limited transportation infrastructure. Many communities, particularly indigenous populations, live in remote areas that are only accessible by river or unpaved roads, making healthcare delivery more complex compared to urban centers. Malaysia has established legal frameworks such as the Private Health Facilities and Services Act 1998 and the Medical Act 97, which regulate healthcare services and professional standards. In addition, initiatives such as rural health programs and mobile clinics aim to extend healthcare coverage to remote populations. So in this presentation, we aim to evaluate the existing framework, assess its effectiveness and any unresolved issues, and also consider possible improvements within Malaysia's current context. So next, I will be discussing the existing state of laws, regulations, and policies governing healthcare in Malaysia, with particular reference to Malaysia and Borneo. So firstly, at the constitutional level, healthcare in Malaysia is governed under the Federal Constitution of Malaysia, specifically under the 9th Schedule, List 1, Item 14, matters relating to public health, medical services, and hospitals fall within the federal list, meaning they are under the jurisdiction of Parliament. This constitutional arrangement creates a centralized healthcare system where legislative authority rests primarily with the federal government. As a result, healthcare laws and policies are generally applied uniformly across Peninsular Malaysia, Sabah and Sarawak. This ensures consistency in regulatory standards, administrative structures, and service delivery nationwide. However, while this promotes uniformity, it may not always fully account for the unique geographical and infrastructural challenges faced in Malaysia and Borneo. Moving on to the federal legislation, two key statutes play a central role in regulating healthcare in Malaysia. The first one is the Private Healthcare Facilities and Services Act 1998. This act governs the private healthcare sector, including private hospitals, medical clinics, and dental clinics. Its primary function is to ensure that private healthcare providers operate within a structured legal framework that prioritizes quality, safety, and accountability. In particular, sections 3, 5, 6, and 8 collectively establish the regulatory regime. Section 3 requires healthcare facilities to obtain a license before commencing operations, ensuring that only qualified providers enter the system. Section 5 outlines the application procedures, while Section 6 allows the imposition of conditions to maintain standards of care. Importantly, Section 8 empowers the Director General to approve, refuse, suspend, or revoke licenses. This provides a strong enforcement mechanism, ensuring compliance and maintaining the integrity of private healthcare services. The second key statute is the Medical Act 1971, which regulates the medical profession itself. This act establishes the Malaysian Medical Council, or MMC, which is responsible for overseeing professional standards, ethical conduct, and accountability among medical practitioners. Under Section 14, all medical practitioners must be registered with the MMC, ensuring that only individuals with proper qualifications and competence are allowed to practice. Additionally, Sections 29 and 30 provide the MMC with disciplinary powers, enabling it to investigate professional misconduct and impose sanctions where necessary. These provisions are crucial in maintaining public trust and professional integrity within the healthcare system. Despite the strong federal framework, healthcare in Malaysian Borneo is also shaped by state-level legislation, particularly in the area of public health. In Sabah, public health is governed by the Public Ordinance 1960, while in Sarawak, it is governed by the Public Health Ordinance 1999. So these ordinances empower local authorities and public health officers to administer and enforce public health measures within their respective states. For instance, in Sabah, Sections 3 to 5 outline the administrative roles of local authorities, while in Sarawak, Sections 3 to 6 provide for the appointment and functions of public health officers. This decentralized element allows for localized enforcement, which is particularly important given the rural and remote nature of many communities in Sabah and Sarawak. In terms of their core objectives, these ordinances focus on three main areas. Firstly, environmental health and sanitation. In Sabah, Sections 39 to 41 address the protection of water supply, while in Sarawak, Sections 23 and 29 regulate food hygiene and in sanitary premises. These provisions are essential in preventing health risks such as waterborne diseases, food poisoning, and the spread of bacteria due to poor sanitation. Secondly, disease prevention and control. In Sabah, Sections 11 to 13 require the notification of infectious disease, and Section 19 provides for the isolation of infected individuals. Similarly, in Sarawak, Sections 10 to 12 focus on investigation and control measures, while Sections 14 and 15 regulate movement from infectious areas. These mechanisms are particularly important in rural regions where access to healthcare facilities may be limited, making early detection and prevention the primary line of defense. Thirdly, the ordinances provide for preventive and enforcement powers. In Sabah, Section 23 allows entry and inspection of premises, while Section 24 authorizes disinfection of infectious areas. In Sarawak, Sections 56 and 58 empower authorities to conduct investigations and close unsafe premises. These enforcement tools enable authorities to act proactively, reducing the need for hospital-based treatment by controlling health risks at an early stage. So, for the next part, I will be passing to my fellow members to explain the next issues. Thank you.
Thank you and good day to Dr. Wilson and my fellow group members. My name is Zara Tanjin and today I'll be presenting on the current unresolved healthcare issues in Sabah, Sarawak, as well as the practical and realistic solutions that could help address these long-term standing problems. Firstly, it is important to understand that the healthcare challenges in Sabah and Sarawak are not caused by a single issue, but rather by a combination of sanitation problems, environmental health concerns, disease control difficulties, and healthcare infrastructure shortages. These issues are interconnected and together they create a significant barrier to healthcare accessibility in East Malaysia. The first major issue is poor sanitation and environmental health conditions, particularly in rural areas. A significant portion of the Sabah and Sarawak live in rural remote areas where clean water supply and proper sewage systems and waste management infrastructure are still considered insufficient. According to the government and public health reports, rural pipe water coverage in certain districts in East Malaysia is still significantly lower in urban areas, and some rural communities still rely on untreated water sources such as rivers and rainwater for daily use. This sanitation issue directly contributes to the preventable diseases such as waterborne diseases such as cholera and diarrhea, vector-borne diseases such as malaria and dengue, parasitic infections, and malnutrition due to poor living conditions and repeated infections. From a public health perspective, the World Health Organization, or WHO, has consistently stated that clean water sanitation and hygiene are the most important factors in preventing infectious diseases, especially in rural communities. This poor sanitation does not just cause illness, but also increases healthcare costs increase hospital admissions, and places a heavy burden on rural clinics that already have limited staff and equipment. In addition, poor road infrastructure makes this situation worse. Many rural villages are located far from hospitals, and patients often need to travel several hours by boat or even poorly maintained roads just to reach the nearest clinic. This delay in treatment can turn otherwise treatable illnesses into life-threatening conditions. Another related issue is the lack of distribution of hospital facilities. Hospitals in East Malaysia often have fewer beds, fewer specialists, and fewer diagnostic machines compared to hospitals in Peninsular Malaysia. For example, older hospitals such as the Hospital Duchess of Kent faces difficulty expanding due to land constraints and outdated infrastructure. In districts such as Sadakan, there are no private hospitals, only private clinics and one public hospital, which increases the pressure on public healthcare system. Second, there is a major issue in difficulty in controlling infectious disease in Sabah and Sarawak. One of the main reasons for this is geography. East Malaysia shares borders with Brunei, Philippines, and Kalimantan, Indonesia, where there is frequent cross-border movement, often from work to trade and family visits. Some even have to travel daily. This frequent movement makes disease surveillance and health screening more difficult as individuals may cross borders without proper health monitoring. This issue became very clear during the COVID-19 pandemic, where border movement contributed to the spread of infection. However, even after COVID-19, other infectious disease remain a concern in East Malaysia. For example, rabies cases have been reported mainly in Kota Kinabalu, KK, and Bintulu, with 6 deaths recorded as of December 2025. Malaria, such as Pallidum classii, also is rare, however is most common in Sabah and Sarawak due to forested environments. Tuberculosis rates in Sabah Sarawak are also among the highest in Malaysia. Reports have shown that Sabah alone consistently records one of the highest tuberculosis incidence rates in the country, contributing a significant percentage of the national tuberculosis cases. These statistics show that the disease control in East Malaysia is not just a local issue, but a national public health issue. Infectious diseases do not remain in one area, where in turn they spread to other states and affect the whole country if not properly controlled. This third issue is the public health nuisance and environmental pollution, particularly improper waste disposal and illegal dumping. In many rural areas and semi-urban areas in Sabah and Sarawak, waste management systems are not as efficient, leading to open dumping and burning waste. This creates several health risks, such as breeding grounds for pests, such as flies and cockroaches and rats, which spreads diseases. Open burning produces toxic smoke, which can cause respiratory problems such as asthma, coughing, and breathing difficulties, and contaminated soil and water sources affecting nearby communities as well. Enforcement is often difficult due to the lack of manpower to survey, lack of funding, and the need to balance environmental protection with the economic development, especially in areas such with logging and plantations or construction projects. Another issue within the healthcare system itself is the shortage of healthcare workers in East Malaysia. Many doctors and specialists prefer to work in Peninsular Malaysia due to better facilities and career opportunities. As a result, hospitals in Sabah and Sarawak often face staff shortages, long waiting times, and overcrowded wards. Here we are going to discuss the second part of my Now I will move to the second part of my presentation, which is the practical solutions that are realistic and feasible in addressing the issues. Firstly, the government should build more medical centers and upgrade existing hospitals in Sabah and Sarawak. This is necessary because the current number of hospitals, beds, and specialists is not enough to serve the population, especially in rural districts. Studies and government reports have shown that thousands of additional healthcare workers are needed to support hospital operations in East Malaysia. Increasing the number of hospitals alone is not enough, and that the government must also increase the number of doctors, nurses, lab technicians, and public health officers working in these areas. The government has also started on some initiatives such as upgrading the Miri Hospital and increasing the bed capacity at Lawas Hospital, which shows that improvement is possible, but more projects are still needed to be done to close the healthcare gap between East and West Malaysia. The second solution is to increase the budget for infrastructure development, especially water supply, sewage systems, and road infrastructure. Improving sanitation infrastructure can significantly reduce diseases such as cholera, diarrhea, typhoid, and parasitic infections. Clean water allows people to cook, wash food, bathe, and maintain personal hygiene, which is directly reducing disease transmission. According to the World Health Organization, improving sanitation and clean water access can reduce diarrheal diseases up to 30 to 40%, which shows that infrastructure investment is actually a public investment, not just a development project. Better roads are also important because they allow faster transport for patients to hospital, faster delivery of medical supplies, easier movement of healthcare workers to rural clinics, and this is especially important in emergency situations where time determines survival. The next solution is to strengthen disease surveillance and preventive healthcare, especially in border areas such as Miri and other towns near international borders. Preventive measures should include pre-travel health education, mandatory health screening for high-risk areas, chemoprophylaxis for malaria workers and entering the endemic areas, and early health screening programs in rural and close border communities. Preventive healthcare is more cost-efficient than treatment. Detecting diseases early reduces hospitalization, costs reduces death. Detecting diseases early reduces hospitalization costs, reduces death rates, and prevents outbreaks. Another important solution is for stricter enforcement of law against littering, illegal dumping, and open burning. For example, Malaysia has introduced community service punishments for littering, which is a good step towards improving the public cleanliness. Countries like Singapore have very strict anti-littering laws, and as a result, they have cleaner environments where fewer pests and fewer environmental health problems. This shows that strict enforcement can actually change public behavior and improve public health outcomes. In high-traffic areas such as Pan-Borneo Highway, stricter monitoring and enforcement should be implemented because illegal dumping often occurs in these areas. Finally, there should be more public health care education and awareness programs, especially in rural areas. Many rural residents may not have the access to Many residents may not have access to accurate health information and may rely on traditional remedies until illnesses become serious. The healthcare education programs can include hygiene education in schools, disease prevention campaigns, vaccination awareness programs, and social media campaigns to fight fake medical news. Health literacy is very important because Health literacy is very important because a population that understands disease prevention will reduce the burden of hospitals and clinics. To shorten, the healthcare issues in Sabah and Sarawak are mainly caused by poor sanitation, weak infrastructure, disease control challenges, environmental health issues, and healthcare workforce shortages. These problems are interconnected and require long-term structural solutions. Not just a temporary fix. The most practical and feasible solutions include building more hospitals and increasing healthcare workers, increasing infrastructure and sanitation funding, strengthening disease surveillance and preventive health care, stricter enforcement of public health and environmental laws, and increasing public health education and awareness. If these solutions are implemented properly, healthcare accessibility and health outcomes in Sabah Sarawak can be significantly improved, and the healthcare gap between the East and West Malaysia and Peninsular Malaysia can be reduced. Thank you.
Greetings, Dr. Wilson. My name is Fatin Nabila, and before I begin, my friends have thoroughly laid out the existing legal frameworks governing healthcare in Malaysia and the severe unresolved accessibility issues in Sabah and Sarawak. We have seen how the current constitutional arrangement under the 9th Schedule, List 1, Item 14, places public health, medical services, and hospitals squarely within the jurisdiction of the Federal Parliament. This creates a highly centralized healthcare system designed to apply uniformly across Peninsular Malaysia and also Sabah and Sarawak. However, our analysis highlights a critical flaw. A uniform law does not equal uniform accessibility. My other group member also outlined several practical solutions to these issues, such as creating more medical centers, increasing the infrastructure budget for East Malaysia, and enhancing public education and surveillance. Also, establishing stricter enforcement for health nuisances. So my segment for this presentation will critically analyze Part D, which is the specific reforms to laws, regulation, and policies required to actualize these solutions, followed by Part E, an evaluation of the likelihood that these reforms will be implemented in our current socio-political climate. Let's begin with the first major area of reform, which is the infrastructure and sanitation. At present, many parts of East Malaysia continue to struggle with poor sanitation. In some areas, proper sewage systems are lacking and pipe coverage remains at around 60%. The consequences are not abstract, and they are felt daily through rising cases of waterborne diseases, parasitic infection, and even malnutrition. These preventable conditions place a heavy and constant burden on already stretched rural clinics. At the same time, weak road infrastructure makes it far more difficult to deliver medical supplies, send personnel, staff or medical personnel, or even transport patients. So now let's begin with the proposed reform number 1, which is the enactment of a National Health Enabling Infrastructure Act. So a practical way forward would be for a parliament to introduce a new federal law or at least a binding regulatory framework under the Ministry of Health that directly addresses this long-standing gap. The goal is not to complicate the system, but to connect what has always been treated separately, healthcare and infrastructure, that makes it possible. So this reform starts by rethinking what we mean by public health. Clean piped water and accessible roads should not be seen as optional add-ons or purely local concerns. They are basic conditions for any functioning healthcare system. By formally recognizing these utilities as part of public health under the Federal Constitution, the law would acknowledge a simple reality. Healthcare does not begin in hospitals. It begins in the environments people that live in. More importantly, this legal shift will carry real consequences once these elements are defined as health prerequisites. Both federal and state governments will be required to work together in funding and implementation. The current situation where responsibilities are fragmented and easily shifted will no longer be sustainable. Instead of operating in silos, there will be a clear shared mandate to ensure that no community is left without essential infrastructure, including those that's still facing severely limited PIPE coverage. So, in essence, this reform is about turning what is already understood in practice into something that is finally enforced in law. This brings us directly to the second key reform, which looks at how healthcare funding is actually decided and distributed. Furthermore, the next reform is the East Malaysia Health Equity Budgetary Policy. So at the very moment, federal healthcare funding is largely centralized and guided by general policy considerations. So in practice, this often means that areas with higher population density, mainly in Peninsular Malaysia, receive greater attention and resources. While this may appear fair on the surface, it does not reflect the very different realities faced in East Malaysia. If we are serious about improving healthcare outcome in Sabah and Sarawak, funding cannot continue to be based on the broad idea of equality, where everyone is treated the same. Instead, it needs to shift towards equity, where resources are distributed based on actual need and existing disadvantages. To achieve this, we propose reforming the Ministry of Health internal financial framework by introducing a legally binding equity formula to guide annual budget allocations. So this formula would take into account the unique challenges of East Malaysia, its geography, the wide population, difficult terrain, and long-standing infrastructure gaps, all of which make healthcare delivery more complex and costly, including efforts to control and prevent diseases. So by embedding these factors directly into the funding mechanism, allocations for East Malaysia will not longer depend on changing political priorities or discretionary decisions. Instead, they will be guided by clear legal and administrative requirements. This will ensure more consistent investment in critical areas, including the development of new medical centers, while also supporting the broader infrastructure needed for effective healthcare delivery. So in short, this reform is about making fairness meaningful by ensuring that those who face greater challenges are given the support they actually need. The third proposed reform is decentralized and mandated public health regulations. This reform focuses on strengthening how public health measures are actually carried out on the ground. To do this, changes are needed within the regulatory framework under the Prevention and Control of Infectious Diseases Act 1988 or similar federal health regulations. First, there should be a shift from merely advising preventive measures to making them legally enforceable where necessary. For example, pre-travel health education and chemoprophylaxis for individuals heading into malaria endemic areas should be made mandatory, particularly for workers who face repeated exposure. Right now, these measures are often recommended but not strictly followed, which increases the risk of the transmission and outbreaks. By making them a legal requirement, prevention becomes more consistent and effective. Second, and just as importantly, public health policy needs to move close to the communities it serves, instead of relying heavily on centralized hospital systems, which many rural patients struggle to access due to distance and poor infrastructure. The law should actively support decentralized, community-based screening. This means giving local health workers both the legal authority and the financial support to carry out early detection efforts, especially for diseases like tuberculosis or TB. Empowering local healthcare providers in this way allows for earlier diagnosis, faster intervention, and ultimately better health outcomes. It also recognizes a practical reality. In many remote areas, waiting for patients to reach hospital is simply not effective. Healthcare must go to the people, not the other way around. Together, these changes would make public health responses more proactive, accessible, and grounded in the realities of the communities they are meant to protect. Last but not least, the final reform is amending state public health ordinances. We propose structural amendments to both the Sabah and Sarawak public health ordinances. The first one is the Politer-Pace Amendment, which the ordinances must be reformed to include a strict liability polluter-pays regulatory mechanism. When industrial or commercial economic development creates a contaminated environment or poor drainage, the financial burden of remediation and the healthcare costs of the affected community must legally fall upon the developer. Second is the ring fencing enforcement funds. To address the lack of resources, the ordinances should be amended to establish a dedicated, legally protected, public health enforcement fund generated from industrial licensing fees, ensuring that local health inspectors have the travel budget and equipment required to monitor remote and rural areas. Now, I will now move to part E of the analysis, which is how likely it is that these reforms will actually be implemented in Malaysia's current context. The first likelihood is disease surveillance and nuisance enforcement policies. So among the reforms proposed, the measures under Reform 3, particularly those related to disease surveillance and stricter enforcement under state-level nuisance laws, are the most likely to be implemented in the near term. The main reason is just simple. The data is too urgent to ignore rising rabies fatalities, the re-emergence of malaria, and the fact that Sabah and Sarawak together account for a disproportionately high share of tuberculosis or TB cases, all point to immediate public health risk. These are not long-term abstract concerns, but they are active and visible problems that demand quick responses. Because of this, both federal and state governments have strong incentives to act. Localized outbreaks carry the risk of spreading further and disrupting the economic activity, which makes them politically and economically sensitive. In such situations, targeted regulatory action becomes the most practical response. Importantly, these types of reforms are also easier to implement. Measures like mandatory chemoprophylaxis or stricter enforcement of local nuisance regulations do not always require sweeping legislative changes. They can often be introduced through ministerial directive, regulatory amendments, or state-level decisions. These make them faster, more flexible, and far more politically feasible in the short term. The second is the moderate to low likelihood is the major constitutional and financial overhauls. In contrast, the chances of implementing the larger, more structural reforms, namely the National Health Enabling Infrastructure Act, which is the Reform 1, and the East Malaysia Health Equity Budgetary Policy, which is the Reform 2, are, at least in the short term, more limited. This is despite how urgently they are needed. There are two main reasons for this. So the first one is the barrier of bureaucratic centralization. Malaysia's healthcare system has long been shaped by a strong centralized structure. So in practice, this means federal ministries tend to retain tight control over decision making, especially when it comes to funding. Proposals that require them to legally commit to a fixed, equity-based allocation formula, particularly one that channels significantly more resources to East Malaysia, are likely to face resistance. This is not necessarily due to a lack of awareness, but rather competing priorities. Policymakers often feel pressure to allocate resources where population density is the highest, which naturally favors Peninsula Malaysia. So as a result, any reform that appears to lock in a redistribution of funds may be seen as politically and administratively difficult to justify. So lastly is the economic constraints and development trade-offs. Beyond institutional resistance, there is also the issue of cost. So addressing the infrastructure gaps such as closing the significant shortfall in pipe coverage or building new medical centers across the challenging terrain of Sabah and Sarawak will require substantial financial investment. So in reality, the government is constantly balancing multiple development priorities from economic growth to infrastructure, expansion, and social services.
Thank you to Bing and Fatin for their explanations. So before I conclude our presentation, I would like to highlight an additional relevant aspect for this discussion, which is cultural sensitivity and community trust. So healthcare accessibility is not determined solely by physical availability of services, but also by whether those services are culturally accepted and trusted by the communities they are intended to serve. In Sabah and Sarawak, this is particularly significant due to the diverse indigenous populations and their unique belief systems. Firstly, cultural beliefs and traditional practices play a major role in shaping healthcare behavior. In many communities, illness may be interpreted through spiritual or supernatural perspectives, and individuals may rely on traditional healers or herbal practices are deeply rooted in cultural identity. They may sometimes delay engagement with modern medical treatment, affecting timely diagnosis and care. Secondly, language and communication barriers further reduce the effectiveness of healthcare delivery. Many rural populations speak local dialects or indigenous languages, while healthcare providers are often non-local. This mismatch can lead to miscommunication, misunderstanding of medical advice, and poor treatment compliance. Additionally, there is often a lack of trust in the healthcare system. Perceptions of cultural insensitivity or limited community engagement may result in reluctance to seek formal healthcare, with some individuals preferring alternative or familiar methods of treatment. Importantly, existing legal frameworks do not fully address these cultural barriers, creating a gap between the availability of healthcare services and their actual utilization. As a result, this may lead to delayed diagnosis, poorer health outcomes, and reduced effectiveness of healthcare policies overall. So to conclude our presentation, while Malaysia has established a comprehensive legal and regulatory framework governing healthcare, including the FC, the Private Healthcare Facilities and Services Act 1998, and the Medical Act 1971, significant challenges remain in ensuring equitable access to healthcare services in Sabah and Sarawak. The analysis of existing laws demonstrates that although the system is structurally strong and promotes uniform standards nationwide, it does not fully address the unique geographical, infrastructural, and social-cultural realities of nation Borneo. As highlighted, issues such as poor sanitation, limited infrastructure, disease control challenges, and healthcare workforce shortages continue to hinder effective healthcare delivery in these regions. Our discussion has also shown that practical solutions, including improving infrastructure, increasing healthcare workforce, strengthening disease surveillance, and enhancing public health education are both necessary and achievable. However, to ensure long-term impact, these solutions must be supported by targeted legal and policy reforms. In particular, reforms such as a health-enabling infrastructure framework and equity-based budget allocation and stronger decentralized public health measures are crucial in bridging the gap between policy and actual healthcare accessibility. At the same time, it is important to recognize that healthcare accessibility is not solely a legal or structural issue. Cultural sensitivity and community trust play an equally vital role in determining whether healthcare services are effectively utilized. Without addressing these human and social dimensions, even the most well-designed legal frameworks may fall short in practice. Ultimately, achieving equitable healthcare in Malaysian Borneo requires a holistic approach that integrates legal reform, infrastructure development, policy commitment, and cultural understanding. Only through this combined effort can Malaysia move closer to ensuring that no community is left behind in accessing quality healthcare. By that is the end of our presentation. Thank you so much, Dr. Wilson, for listening, and have a good day.